Yesterday we presented the data of the PRIMA OE26 GOG3012 trial. What is the background of this study? So we have many patients with advanced ovarian cancer that do have a high risk of early relapse at the end of the chemotherapy. Nowadays we have opportunities for maintenance therapy, but that is not applicable for all the patients. For instance, we can use olaparib, but only for BRCA mutated patients. And the other option, that is bevacizumab, can have a limited use in some patients due to safety concerns, and also in other patients that do receive neoadjuvant chemotherapy, because we don't have good data from randomized studies addressing the issue of the incorporation of bevacizumab in the neoadjuvant setting. So there is still a high unmet need for many patients. We had data for Niraparib, which is an oral PARP inhibitor, in the recurrent setting. Patients that do recur and respond to platinum, where they receive Niraparib, they significantly prolong the progression-free survival, regardless of the situation of the BRCA or the homologous recombination status. So the hypothesis that we have tested is if adding Niraparib after frontline chemotherapy in patients that have finished the chemotherapy and have obtained a response could improve the outcome of these patients of high risk of early relapse. To try to answer this question, we designed a randomized trial, a phase 3 randomized trial. We have included patients with high-grade serous or endometrial cancer. Patients were defined to have high risk according to stage 3 with macroscopic residual disease after the frontline chemotherapy, or stage 3 that were treated with neoadjuvant chemotherapy regardless of the result of the interval debulking surgery, and any patient with stage 4. All patients needed to have a response. All patients were platinum responders, either complete or partial responders. And for all the patients, we tested also the homologous recombination status according to the myriad my choice test. Patients were randomized 2-to-1 to Niraparib or placebo, and the Niraparib was given once a day for 36 months or until disease progression. Patients were stratified according to the use of neoadjuvant chemotherapy, yes or not, best response to chemo, complete or partial, and also the tumor status according to homologous recombination, proficient, deficient, or not determined. The primary endpoint of our study was progression-free survival. It was measured by a blinded independent central review, and we tested it hierarchically. So we did first the PFS analysis of the homologous recombination deficient group, and if that was positive, then we performed the analysis in the whole population. The study included 733 patients. Globally, patients had bad prognosis, as I mentioned before. 35% of patients had a stage 4, 2/3 of the patients have received neoadjuvant chemotherapy, 30% of patients achieved partial response as best response to chemotherapy. So what was the impact of adding Niraparib to this heavily population of high risk? Well, the addition of Niraparib after chemotherapy in the homologous recombination deficient group, according to our hierarchical analysis, showed a clear decrement in the hazard of progression or death by 57%, and a clear prolongation of the median progression-free survival from 10.4 to 21.9 months. Then we performed the analysis of the overall population. And what we observed is that adding Niraparib reduced the risk of relapse in the whole population by 38%. and prolong the median progression-free survival from 8.2 to 13.4 months. So this is really demonstrating the benefit of niraparib in the whole population. But we performed several pre-planned sub-analyses, and one of the most important was the sub-analysis according to the biomarker status, according to the homologous-recombination status. What we observed is that in the homologous-recombination deficient group, the benefit was very similar between the BRCA-mutated patients and the BRCA wild-type patients. Hazard ratio was 0.4 for the BRCA-mutated, 0.5 for the BRCA wild-type. And if we move to the homologous recombination proficient, niraparib also benefited them with a hazard ratio of 0.68. So this is the first time that we have observed a benefit with the addition of PARP inhibitors in front line, regardless of the status of the biomarker. Regarding the safety profile, what we observed is that the safety profile of niraparib was consistent with prior studies with niraparib, essentially with the NOVA study. So, in summary, the addition of niraparib reduced the risk of progression of a population of patients that do have a high risk of early relapse. This benefit is observed across the biomarker status. It was, I would say, higher in the BRCA mutated, but the benefit was also observed in the BRCA wild type deficient and in the HRD proficient group of patients, and no new safety signals were detected. So we think that the addition of niraparib after frontline chemotherapy should be considered a new standard of care for our patients with advanced ovarian cancer.